Perfect. It's almost good afternoon. Good morning, everybody. We'll just wait another minute or two, and then we can get started with our PodMed 101 series with Dr. Wendy Cole. All right, well, good afternoon, everyone. We're very excited to welcome you here for our PodMed 101 series with Dr. Wendy Cole. Dr. Cole is here today to present a case study in wound care. Before we get started, I want to take an opportunity just to introduce our office before I introduce Dr. Cole. I'm Carla Rodabaum. I'm the Director of Enrollment Management and Student Services at the college, and we're also joined by Angela DeSavos. Angela is our Assistant Director of Enrollment Management at Kent State University College of Podiatric Medicine. But the main reason we're here today is to spend some time with Dr. Wendy Cole. I'm going to give a brief introduction, Dr. Cole, and then let me know if I've forgotten anything because there's a lot to cover when I look at your background. Dr. Cole is an adjunct faculty member here at KSU CPM and also the Director of Wound Care Research. Dr. Cole, you grew up not so far away from Cleveland in Youngstown, Ohio, graduated with an undergraduate degree at the University of Cincinnati, and then attended the Ohio College of Podiatric Medicine, now, of course, Kent State University. You are board certified by the American Board of Podiatric Surgery and a fellow of the American College of Foot and Ankle Surgeons. Active member, national organizations, and even state organizations as well. But I think what's really impressive is that you've been in practice for nearly 20 years here in Northeastern Ohio, and really have a focus and have made a name for yourself within wound care and wound care research. Dr. Cole is obviously a big name in the profession, but you lecture all across the country when it comes to wound care. I feel like I'm always seeing something new that comes out with research in wound care, and your name is right there next to it. So I'm very, very excited to have you here today, a leader not only in wound care, but a leader in the field, to share some insight with us and our prospective students about podiatric medicine and wound care research. So with that, I will turn it over to you, Dr. Cole.
Thank you so much, Carla. That's a great introduction. And I want to just thank the students for joining us today, and hopefully we have some time after the presentation for some questions you might have. So I decided to talk to you briefly today about improving wound debridement through the use of advanced wound imaging tools. Here at KSU CPM in the Wound Care Research Department, we love new technologies and new toys and figuring out how these really can integrate into the care of our patients. And this is one such case series that we published recently on a new technology and a new device. So we'll go through some of that now. So the objectives for this talk is to evaluate how biofilms and bioburden impair wound healing and chronic wounds. We will describe some ongoing research in biofilms and the treatment and management of biofilms in chronic wounds. And we're going to review a recent advanced wound imaging tool and how we have implemented that in our clinical practices in order to help improve patient outcomes. So acute wounds heal by a progression through this complex series of overlapping steps. But most of the time in our wound care practices, in our patient offices, in our hospitals, we're not seeing patients with acute wounds, we're seeing patients with chronic wounds. So somewhere along this continuum, these wounds have stalled or have not progressed on to healing. They didn't get the memo, they're stuck, and they're usually stuck in the inflammatory process, and they are unable to heal. And we have to do what we can as podiatrists and wound care clinicians to help these wounds to get back on that healing trajectory. So chronic wounds have stalled for a variety of reasons. Typically, we see high bacterial burden or microbial burden, and then also excessive devitalized tissue. Those are some of the major causes for wounds to stall in the continuum of the wound healing cascade. And it has been reported that about 70 to 90% of all wounds that we are seeing in our offices and our hospitals and our clinics are chronic or stalled wounds. And we really categorize wounds that haven't healed by 40 to 50% in 4 weeks as chronic or stalled wounds. But we see wounds that haven't healed in 4 weeks, 4 months, sometimes 4 years or more, typically in our wound care centers. So within 24 hours of a wound forming, bacteria from the environment or from the normal skin flora can invade the wounded tissues. And this is when wound healing can potentially be compromised. This bacteria can cause acute wound infections, abscess, osteomyelitis, and sometimes it doesn't cause an acute wound infection, but it contaminates the wound environment, and that could also be problematic as well. So as a wound care provider, podiatrist, clinician, we need to do regular wound debridements on these chronic wounds. Regular debridements is really the crux or a crucial part of wound healing. And it's a standard of care to remove that unhealthy devitalized tissue by sharply debriding or enzymatically debriding, or there's other methods of debridement we'll kind of touch on as well. The reason is that this unhealthy or devitalized tissue really is a blockade for healing. It allows for areas, nooks and crannies, if you will, for active bacteria to kind of implant into the wound and cause an infection. We have to remove all that devitalized tissue in order to really ascertain the extent of the ulcer and see how deep it is and how wide it truly is, and see if there are exposed deep tissue structures like tendons, if there's any tunneling or burrowing or deep tracking, or even possibly abscess formation. And then we need to really see what the peri-wound tissue looks like, because the peri-wound tissue is really important in wound healing. Wound healing is kind of a game of Red Rover. We need those little precursors to epithelial cells to kind of crawl across the wound. And if the edges are unhealthy, or if there's rolled edges, which we call epibole, because these wounds have stalled, we'll see these wounds not be able to epithelialize. So the goal of wound care is to really create this environment that's favorable to healing. Our body wants to heal. We just have to give it the proper environment with which to do so. So removing this necrotic or non-viable tissue, as we discussed, is really important, and it helps to get these wounds out of that inflammatory cycle. So there's traditional methods of debridement, surgical debridement, where you take a 15 blade or a curette and you're forcibly remove that devitalized tissue. That's most common, what we do in our offices and our wound care centers. Autolytic debridement, sometimes we cover wounds with occlusive dressings and kind of let the body's own enzymes digest devitalized tissue. You know, this is messy and it takes a long time, so it's not one of my go-to ways of debridement. Enzymatic debridement, there's medications on the market. Collagenase Santal is one of them that we use for enzymatic debridement with pretty good luck, but it is also a slow process. Maggot debridement, which you may have heard of. I have not used biologic debridement, although I've had patients come into my clinic with maggots in their wounds. Those are very clean wounds, but I've never utilized biologic debridement personally. Hydrosurgical debridement and ultrasonic debridement, those are methods that we employ typically in the OR to remove large masses of devitalized tissue. Specifically on patients that can't tolerate a bedside debridement or surgical debridement. If we take them to the OR, we could put them under anesthesia. We could use hydrosurgical or ultrasonic debridement to remove all that necrotic or devitalized tissue, and the patient is comfortable as well. So in some cases, though, although debridement is really the best way to remove divided tissue, there still is some bacteria and some contaminants that remain in the wound, and those could be very problematic. So what we found in different studies and different research that's out there is that bacteria left behind after a debridement can reform into what's called a biofilm construct in as little as 24 hours. So just a little bit about a biofilm. We talked about, infective bacteria, those active planktonic bacteria that cause infection, abscess, osteomyelitis. Biofilm bacteria are a little bit different. They start out as planktonic or active bacteria, and they contaminate the surface of the wound. And instead of causing an infection, they actually implant into the wound surface, and they sort of become senescent. They don't actively replicate, but what they do is they form connections with their friends. So there could be different types of bacteria, fungi, yeast, and they all form these connections, and they do something called quorum sensing. So they share information, they share DNA, they can share resistance to antibiotics, and they form this little microcolony, and they start to create something called an extrapolymeric substance. This extrapolymeric substance is very difficult to penetrate with topical agents, and oral and IV antibiotics won't penetrate it either, because again, these bacteria are not actively replicating. While debridement is very effective in removing biofilm bacteria, we see that in as little as 24 hours, biofilm bacteria could start to reform because they spread perivascularly or underneath the wound surface. So they're really hard to get rid of, and doing a good, thorough, and a deep enough debridement is really important, because really you can't treat what you can't see. So now there's new technologies that are entering into the market that allow us to really visualize this bacteria so that we can ensure that we remove it adequately with our debridements. And so that's what we're going to talk about now. So this new device, it's an autofluorescence device. We've been using it here at the Wound Care Research Department. We've published several different trial results on it. It's a point of care, which means we use it directly at clinic, at bedside. It's about the size of a cell phone, so it's very portable, and it can help us really determine where the bacteria are and where the dividalized tissue are, and aid our debridement. So what it picks up is bacterial loads that are 10 to the fourth colony forming units or greater. So pathologic or bad levels of bacteria. Clinically infected wounds are thought to have bacterial levels of 10 to the fifth or 10 to the sixth colony forming units. So we can pick these up just underneath where they would become clinically infected. So that's really important to kind of stop that infection so patients don't have to have antibiotics, be hospitalized, and undergo surgery. So how this device works is it's a safe, a violet light that we shine on the wound. It has to be a dark environment so that we can visually detect the abnormal tissues and bacteria. But this violet light excites surface bacteria so that we can do our good, thorough debridements. It also can take standard images. So it's really important when we're tracking wound healing. We want to see that the wound area is reducing over time to show that what treatments we're using are effective. So it can track by determining digital measurements weekly on patients, but then it's that fluorescence image or that violet light image that's really important, because we'll see surface bacteria either fluoresce red, or Pseudomonas will fluoresce what we call cyan, or kind of a bright greeny blue. And I'll show you some other pictures. So you can see this standard image of a wound. There's some dividalized tissue, but it doesn't look acutely infected. There's no purulent discharge. The peri-wound area is not really erythematous or red, and there was no malodor clinically. But when we use the fluorescence imaging device, we see that it lights up, if you will. So you see that kind of bright greeny appearance, that's Pseudomonas bacteria. And then the pink appearance around the wound, that is porphyrin producing bacteria, and that will fluoresce a pink or a red. So here's just some examples of the bacteria that will fluoresce under the violet light camera. So a lot of our typical beta actors that we see in wounds, Staph aureus, we see Enterobacter, E. coli, Pseudomonas we talked about. So we can pick up gram negatives, gram positives, and anaerobic species as well. And they'll fluoresce white, or excuse me, they'll fluoresce red, while the Pseudomonas is the only one that fluoresces that cyan. It's a little different. So we talked about the biofilm and how they are in this protective matrix that's difficult to penetrate with antimicrobials. So really being able to detect the biofilm and the bacteria utilizing the fluorescence is very helpful in our debridement and proving that our therapies are effective and getting patients to heal quicker, which is why we're doing what we're doing. It differs from a Woods lamp because a Woods lamp is not selective, where this fluorescence imaging camera is very selective in autofluorescence bacteria. So it's much more effective than a Woods lamp. And you can see the red bacteria show up here, and that's evidence that there's bacterial infection in and around this wound. And here's just a little video showing debridement utilizing the fluorescence imaging. So I'm going to talk to you about an expanded case series and a couple cases that was in this expanded case series. So we looked at 11 lower extremity chronic wounds, so legs or foot, and we took images of bacterial fluorescence, and then we also took standard images to track wound measurements over the course of 12 weeks or sooner if the patient's healed. So these positive fluorescence images were used to guide our debridement. So upon initial intake, patients were either thought to be fluorescence positive if they lit up on the camera picture, or fluorescence negative if we didn't see any fluorescence. And then we tracked those weekly wound area reduction changes, or I shouldn't say reduction, wound area changes either increasing or reducing depending on what was going on in the wound at that time. So here's a patient case. This is a 67-year-old female. She had a history of trauma in her lower leg. This wound, it was chronic. It had been open for 16 weeks. Clinically, there was no evidence of acute bacterial infection. You can see the standard image and the measurements that were taken. And then we took our fluorescence image and we see all those pinpoint areas of a kind of red little dots. So we know that that bacterial contamination is in and around the wound. So decided to do a debridement with her, and then we used an enzymatic debriding agent with a bacterial binding non-adherent layer, and she changed her dressing daily, and we saw her at our wound care center weekly. So she was doing really well, but all of a sudden at week 5, we see upon fluorescence image this bright kind of starburst appearance of red around the wound. So we were able to catch what we feel is an early cellulitis, put the patient on oral antibiotic therapy, hopefully prevent, hospital admission, any kind of surgical intervention, and long-term IV antibiotic. So we saw her back the following week, and the wound dimensions have decreased. And then you see that peri-wound inflammation and that starburst red appearance had dissipated on the fluorescence image. So we know that that early intervention with oral antibiotics was appropriate for her. Here's another case, 63-year-old male. He also had a trauma. He fell from a ladder, and this wound had been present for 13 weeks. And you can see the standard image and the measurements. There was a lot of devitalized tissue, but it didn't appear acutely bacterially infected, but it was definitely contaminated. You can see the fluorescence images. The first one is pre-debridement and the second one is post-debridement. So even though I was able to get rid of some of that green and bright white appearance of the tissue and even some of the red, I wasn't able to completely remove it with a good thorough debridement. So we also treated him with an enzymatic debriding agent and a bacterial binding non-adherent layer, and we saw him back weekly. So this was the patient at week 5, and you can see on the fluorescence image, nothing lights up. So at week 5, the wound had decreased in measurement significantly. And all of a sudden, we don't see a fluorescence profile when we take the image. So we know that we've rid this wound of all of that contaminant bacteria. And the patient entered into a healing trajectory and rapidly healed, completing his course of therapy in 10 weeks. Here's one additional case, a 71-year-old female, 14-week history of a diabetic foot ulcer, clinically, again, not infected, but that fluorescence image, you kind of see this ring around of the red. So we could sometimes call it the ring of fire. So we know there's bacteria and that's what the reason is that this wound is not healing, is that bacterial contamination. So with her, different treatment mechanism used a collagen matrix with PHMB, which is an antimicrobial, and had her come back the following week. Saw her for additional 3 weeks, and this is what at the 4th week the wound looked like. We were able to get rid of all that fluorescent signal. You see that wound tissue does not light up, so there's no pathologic levels of bacteria, and the patient went on to complete healing by week 5. Here's just another case. You can see where the areas are lit up, and then subsequently with debridement, we're removing that contaminated tissue area to get this patient to heal. So what we found with this case study is that fluorescence targeted debridement did make a huge difference in our patient outcomes. No wound went on to a healing trajectory while there was still positive fluorescence. So while these wounds lit up with bacterial contamination, none of them went on to healing. So weekly changes actually increased in these patients. So the wounds actually got larger when there was bacteria contamination in these wounds. But it was only with the elimination of the fluorescence that we got the result of a decreased wound area or wound healing, and they decreased on average 28% per week once we were able to do thorough debridements and institute of effective antimicrobial therapy to get rid of all that contaminant bacteria. And it was only by the help of this imaging tool that we are able to see these things, because these are things we can't see typically with our naked eye. So 6 of the 11 wounds went on to complete healing in this 12-week trial. When they started, the wounds were 8.1 centimeters squared. So they were pretty large wounds, and all but one showed fluorescence positive imaging upon intake. The one that wasn't positive didn't enter into the study because they weren't pathologically infected or contaminated with bacteria. On average, we saw that fluorescence persisted about 3.7 weeks. So it took 3.7 weeks, almost 4 weeks of debridement and antimicrobial therapy to really rid these wounds of that contamination. And it was our thought that we gained good information from utilizing the device that helped us, again, choose our therapies and really detail our debridements to help these patients go on to heal it more quickly. And we talked about how if there was fluorescent positive, the wounds actually got larger, but once we got rid of all that bacteria, the wounds then entered that healing trajectory. It allowed us to choose the appropriate therapies for the patient and target better and more thorough debridement. And I think that there is definitely the potential to increase patient outcomes when we incorporate these new technologies into our clinic. And that's why we're doing the research here at Kent State University College of Podiatric Medicine. So we can play with all this new technology, determine how it works and where it fits best into our clinical practices. And this is a picture of one of my family vacations years ago to Yellowstone, where the Grand Prismatic Spring is. And this is actually one of a pretty example of biofilm bacteria. That's what gives the prismatic spring its beautiful colors. But in wounds, biofilm bacteria and the pictures that we're obtaining, not so pretty. Here's some references, and I'd be happy to share them with you at a later date if there's interest. And that's really it. I guess we'll open up the floor to any questions. This is my contact information here at the college. If you have any additional questions about research or wound care or the college, I'm happy to answer them for you.
Was fascinating. Just for those on the call, you guys can feel free to jump in with any questions or certainly put them in the chat. I do have one question, Dr. Cole, while we're waiting for some other questions, and that is, you had mentioned that you saw patients in this case study once every week. Is that typical for other studies, this frequent visits with their podiatrist?
Oh yeah, so wound care, standard of care with wound care is seeing patients weekly. A couple reasons. We want to take those wound measurements because it's very important to track these wounds. If the wounds are not responding to our therapy, if they're getting larger or deteriorating, we need to be able to be very active and respond to that and change therapy as needed. We also need to do those debridements, and that's something we have to do regularly because chronic wounds tend to develop devitalized tissue, spent cells, dried slough and debris, and exudate. So that debridement and cleansing of the wounds is very important. And some of our wound care therapies are really only applied once weekly. So standard of care for wound care is seeing patients either in offices, wound care centers, clinics, hospitals, wherever you're practicing on a weekly basis.
Great, thank you for that. I see that Lloyd has a question, so I'll turn it over to you, Lloyd.
Thank you. I was just wondering, has there been any instances of finding where the fluorescence doesn't detect any growth over like a long-term study? Like you see the person doesn't show any fluorescence, but then the wound is infected sometime down the road?
So that's a good question. So I'll tell you that there's been a lot of research to determine that what we're seeing on these fluorescence images is actually pathologic levels of bacteria. So we are actually part of a large study that was published, and I can get you that citation as well. I think there were 350 patients in that study, and it was called the FLAG study. And what we wanted to determine is that the fluorescence positive images that we're seeing on the device actually translate into positive bacterial contamination in the wound. So what we did is we took the camera, we looked at these images in the wounds, and when they fluoresced, we took a biopsy of the area of fluorescence. So we compared what we're seeing on the image of the device and then what we're detecting with that biopsy when they determine that in a lab to see if that bacterial contamination was 10 to the fourth colony forming units or greater, and to see if they meshed, and they did. And then we also took other samples of areas that didn't fluoresce to see if there was bacterial contamination in those areas, and it turned out there was not. So we're pretty sure that what we're seeing on that camera is indicative of what's going on in a pathologic level in the wounds. Now, it's not to say that down the road we have a wound that is bacterial fluorescence negative, and 3 weeks from now they can become contaminated. Absolutely, because these wounds are open to the environment, dog hair, cat hair, lint, bacteria, virus, all of the things. So they can definitely become contaminated down the road, but we know that utilizing this device, we can pretty much hang our hat on. The images are telling us what's going on in a really microscopic level in the wounds.
Thank you.
Certainly. Good question.
Are there any other questions for Dr. Cole that anybody would like to ask before we wrap up this afternoon?
Don't be shy.
I have, I guess, a bit of an informal question. I can imagine that having a tool like this certainly, not necessarily facilitates eases the care of the patient, but it makes it easier for you as a physician to help them progress in their treatment. How much more challenging, I guess, was it before a tool like this was presented to you?
Well, like I said in the talk, we can't treat what we can't see. We assume a lot of things, right? We assume that if the wound isn't progressing, maybe there's biofilm in the wound. We assume that clinical signs and symptoms of infection are enough to determine if these wounds are contaminated. But unfortunately, our assumptions we're learning were wrong. And so having advanced what we call theragnostic tools, so tools that can help to diagnose problems and then also help to determine if our therapies are appropriate, are so important, because previous to this, with our assuming, sometimes we would choose a product or a therapy and we wait to see what happens. And then after 2-3 weeks, we're like, oh, well, nothing happened. It's not improving the outcomes. It's not improving the wound area. So let's choose something else based on different assumptions. But having the tools and concrete evidence to determine what exactly is going on in these wounds will help us choose the more appropriate therapy. So it's going to help us in the long run.
I also have a quick question for you.
Sure.
Do you use a combination of different wound debridement techniques along with this fluorescence? Because like I've heard so many things about maybe like fish skin grafting along. So would you combine various techniques, or would you like solely focus using the fluorescence at first and then maybe down the line use other techniques?
Yeah. So fish skin, as you mentioned, that's not a debridement. That's not a technique for debridement. Fish skin is what we call a cellular tissue product. So fish skin is an acellular dermal matrix, basically derived from fish skin. It's a collagen matrix. The pore size is very similar to human collagen pore size, so it makes it biocompatible. All the cellular debris is removed, so it's non-antigenic, so it won't cause a reaction because it's a xenograft and we're putting it on a human. And yes, I've used many CTPs. Oh gosh, there's a litany. I think there's 75 or 79 CTPs or cellular tissue products out there on the market now. So there's a zillion of them, all with strengths and weaknesses and proven effectiveness. But in this particular case, and in most cases in wound care, the debridement is first. CTPs and other what we call advanced therapies don't come until later. You have to do a good thorough debridement. You have to remove the bacteria. You have to remove the devitalized tissue before you even think about using any kind of advanced dressings like fish skin or another cellular product. So this is step one in a multi-step process.
Gotcha. Thank you so much.
Certainly. Anybody else? Well, if you think of something later, you know how to get a hold of me.
No, that's perfect. And thank you so much for providing your contact information, Dr. Cole. I think that's wonderful. And for those who are on this PodMed webinar, and for those who registered, Dr. Cole was gracious enough to let us record it. So once we have it posted, we'll be able to send it out that way. If you have questions or want to reference something that she said earlier, you'll be able to do so. But I want to thank you so much, Dr. Cole, for spending a little bit of your lunch break with us. So thank you for sharing some insight with our prospective students and some time with us. We really appreciate it.
Oh, my pleasure. Anytime. Thank you.
Wonderful. Thank you all for coming and joining us, and we will talk to you all very soon. Bye-bye.
Bye. Bye. Thanks.
Bye, Dr. Cole. Thank you again.
Oh, no problem. Have a good day.
You too.